So, welcome back to the latest episode of Taking Charge of My Cancer podcast. And I have a great guest today. This is Dr. Erica Braschi. She is a 4-year resident in radiation oncology at the University of Florida. She was born and raised in Puerto Rico, which she grew up loving the beach, school, and competitive tennis. Her passion for tennis brought her to USA and as a teenager for training and tournaments, and later to Elon University, where she played division at tennis and major on biochemistry. During college, while shadowing physicians, she realized how much she valued the patient-physician relationship and felt called to serve others through medicine. She went on and attended medical school at the University of Florida, where she discovered her love for working with patients with cancer. And when she also met her husband, who is now a radiology resident here at UF as well. Within radiation oncology, she especially passion about mentorship, medical education, breast and CNS cancers, palliative care, and finding ways to have meaningful whole person conversation with her patients. She currently serves as the radiation oncology resident medical student liaison at UF and advisory board member of the Keira Grace Foundation. It's a local foundation that funds and supports pediatric cancer in Latin American countries. This year, she was also awarded the University of Florida Outstanding Resident Educator Award. Outside of work, she loves staying active, traveling, and spending time with family and friends. And now she's expecting a little baby as well.
Yes.
So, Erica, thank you so much for being here with me today.
Thank you so much, Darely. I'm honored.
Perfect. So, what drew you to radiation oncology, and how has the patient interaction aspect influenced your perspective?
Yeah, so that's a great question. I feel like a lot of people don't know about radiation oncology when they start medical school, and that was definitely my situation. Um, I would say what first, even before being drawn to radiation oncology, I was drawn to treating patients with cancer, and even before that. What drew me to medicine was, as you mentioned in my bio, was the patient-physician interactions and that relationship. Um, so I really admired how patients entrusted their doctors with lives in such vulnerable situations, and I was very interested in the in humanism within medicine. In going back even a little before medical school and college, I volunteered with hospice, and so really got to see another side of just curing patients, but end of life situations as well. And so I definitely developed an interest in that. And then when I started medical school, I had no idea what I would specialize in, but very quickly and early in my rotations, I was drawn to cancer patients after several interactions with them. I enjoyed having meaningful conversations as they're facing one of the scariest moments of their lives. And I was really honored to be able to walk alongside them in that season and be able to offer support through available medicine and therapies. And so then combining that with my love for science and learning more medical knowledge, it was just medicine was a great fit, oncology in general, and then, I mean, going even further, radiation specifically attracted me because the way that my brain works, I really liked that. In radiation, we're more treatment oriented than diagnosis. So patients come to us a lot of times already with a diagnosis of cancer. We do partake in staging them. And sometimes the workup, but for the most part, is treatment oriented, and I really like that. And then I like time to think about things critically and prepare before I see the patient. I learned that I wasn't my best in high acuity situations, like in the emergency room and the ICU, and I liked rather to be in the clinic and really know a lot about the patient before I even walk in and talk with them. And then, I also like anatomy, imaging, continuity of care during radiation. You're seeing patients on a weekly basis during their treatment and a lot of times for follow-up years after their treatment. So I enjoyed that you continue that relationship. And then it's just really cool, awesome technology that we have. And I like how it's constantly evolving. And so radiation oncology seemed like a great fit. And lastly, I would just add, I think the mentors here at the University of Florida really sealed the deal for me. Some really great radiation oncologists that I aspire to be like.
That's amazing. So you mentioned that you really enjoy looking at the patient as a whole. So would you share a moment when with a conversation with a patient deeply impact you?
Yeah, there are probably so many. The first one that comes to mind is not long ago, during one of my breast cancer rotations. I took care of a lady that was diagnosed with stage 4 breast cancer, and during the consultation, while we were discussing her staging and available treatment options, she became really emotional and very tearful, understandably. She
Mhm.
shared that her goal was to make it to her son's graduation, and she had a special bond with her grandson, and she was worried, given her prognosis and how quickly her cancer was progressing, that she wouldn't make it to that milestone. And those moments, it's kind of hard to find words of compassion or ways to offer hope. But I was just touched by her love and her concern for her family over her own. And I don't typically share personal stories with patients during a visit that's about them. But in this case, I did share with her that my own grandmother battled stage 4 breast cancer many years ago, and that was a major reason why I went into this field. And I saw so much of my grandmother in her that I felt moved to share how much I honored and respected my grandmother and felt close to and supported by her even so many years after her passing. And so we ended up crying together in the patient
Oh,
room. And it was a short and sweet moment of acknowledging that we're human and we love and we suffer, and it's okay to feel strong emotion in these situations. But thankfully, the visit didn't end there. We came up with a plan to treat her palliatively, focus on her goals to control tumor, prioritize quality of life as long as possible. And it's moments like that that are really make this job special to me. We may not cure every patient, but we can offer the best that we have available and be their greatest cheerleaders along the way.
yeah, yep, that is true. And since you mentioned, I've been coming across those conversations as well with some of the patients who are at stage 4 and who I have a particular patient who, 6 years ago, she was told she had 6 months to live.
Mm,
That was 6 years ago.
yeah,
And again, so she is kicking it and she's doing really, really well. Great quality of life, better than ever before,
yeah,
because she's
that's
taking care of
amazing.
her so much more. And yes, it's with the help with some radiation and yes, with the help with some chemotherapy, but it's just really, she used to come and be so upset because she had another pet and another spot. And I was like, well, who cares how many spots you have on your body? As long you feel good, as long you feel that you're not in that much pain and you're enjoying your grandkids and you're traveling and you're doing things that you never dreamed of doing before, that's what matter. So,
Exactly.
and then it's so great to see her then coming back. And she was a guest on the podcast as well,
Wow.
came back to me and I was like, one other time, it's like, oh, Charlie, another pet, another spot, but who cares, right? I mean, completely different attitude,
Yeah, that's
which that was so great to see. So yes, it's about quality of life and enjoying.
right.
And like I always say to my patients, right? Even if you have a stage 4, I mean, we have no idea how long are we going to
Exactly.
keep in it in this world, or, whoever do you believe in, it's
Mhm.
up to him, right? So I tell
Yeah.
patients, I can be totally fine and healthy and come out of here tomorrow and be hit by a bus or have an accident and die. And it's just no way to know when is that going to happen. But in the meantime, just take the best out of your life and enjoy the most of it. So,
Yeah, yeah, I agree completely. We don't have a crystal ball. We don't know
exactly.
who's gonna outlast the statistics that we base our predictions on. Ultimately, we don't decide when that time comes. And so, yeah, I love it, and I'm so encouraged when I see patients that have really just outlived
Yes,
and are still living a good quality of life many years after a poor prognosis was given to them.
exactly. So, what are some of the most common fears or concern patients express during initial consultations with radiation oncology?
Yeah, so there are a lot, and a lot of that depends on how familiar the patient is with radiation. Um, I would say something we come across uh, a lot in those initial consultations are fear from side effects of radiation, from either reading online or seeing a close family or friend go through radiation. And sometimes it was years ago, and our technology has changed so much. And so those can be things, anything from like will my skin burn and just slough off? Or will I be radioactive after my treatment? Do I have to isolate from my friends and family? Am I going to lose all my hair? And I'd say one of the most common things that we have to remind patients is that radiation is local therapy. Most of the time, there are some times where we can deliver systemic radiation, and those are specific situations, but most of the time it's localized targeted therapy. So the side effects are really specific to the certain area that we're treating. And so, for example, a patient who's getting breast cancer treatment is not going to lose their hair from the radiation, and they're a patient getting, I don't know, palliative radiation to their spine is not necessarily going to have the radiation dermatitis. So a lot of it is counseling that the side effects are mainly in the area that we're treating. It's not like systemic therapies like chemotherapies where you may have more side effects elsewhere in the body. And then I think fear that the outcome or the treatment won't be what was desired or what we intended to do, and that the risk may be greater than the benefit. And it's our job to ensure the patient that whatever we're recommending, we're doing so because we believe the benefits to be greater than the risks. And it's important to talk through that with the patient. And so our consults can be pretty lengthy because, maybe the first time that somebody is being introduced to radiation, it's not an ordinary everyday thing that you're getting uh, high energy X-rays aimed at you to target cancer. So you have to really try to ease their nerves, but be realistic about what to expect from the treatment.
And I know sometimes radiation is complex. I mean, I was amazed when I started doing oncology. I have the privilege to spend time with your amazing mentors, but as well, like with the physics and with the, dosimeters, which I didn't even know they exist.
Yeah,
And it's huge complexity behind the scenes. For the patient, they're like, oh, this is easy. I go lie in the bed for like 10, 15 minutes, don't feel anything. And that's easy work, but all the things that go behind the scenes for weeks for you guys to make sure those beams needs to be where it needs to be and target the areas without hurting anything else. So how do
yeah.
you explain these complex treatments to a patient with this newly diagnosed and have no idea what's coming down the path?
Yeah, you were totally right, Durley. There's so much that goes into it that even I had no idea before I started residency. There's a lot that goes into designing the treatment and things that are happening behind the scenes that the patient doesn't even see on a daily basis. But um, explaining it, again, it varies on the patient, what their health literacy is, how familiar they are with the radiation. But I find that I can't say that word, like a
Yeah.
methodological
Yeah.
approach
Yeah.
helps a
Yeah.
lot, like following the same format. And this is something that our mentors here really help us kind of establish early on in residency when you're talking to patients. So I usually start by first asking what they've been told so far about their diagnosis, because you don't want to just jump in and start talking to them about cancer if they've never heard that, or they have no idea what their staging is and things like that. So try to gauge where the patient is. And then I like to summarize what we know so far in terms of the workup, diagnosis, prognosis, management recommendations, and why they were even referred to us.
Yeah.
And then go into details of the treatment, offer frequent pauses to allow the patient to ask questions and family members, because it can be really overwhelming that first visit when you're being bombarded with all of this information. And then when I'm talking about specific treatment details, I think with radiation, it's important to talk about logistics because um, a lot of patients are coming every day for several weeks. And so, um, preparing them for the fact that it's going to be repetitive Monday through Friday most of the time. Many patients are being treated for several weeks. How long are they going to be on the treatment machine? How long is it going to take to set them up? How often do they get to see their treating physician? And then once I'm through the logistics, then I go into the side effects. And those are both the acute short-term side effects, what to expect during treatment and how we're going to manage those. And then long-term side effects that happen months or years after their treatment. And then finally, I always like to discuss what the follow-up plan is going to be. So what happens after they finish radiation? How soon are we going to see them? When are we going to get imaging? Who else are they going to follow up with? Um, and so that approach helps me make sure that I'm offering the most comprehensive explanation about what's supposed to happen. But even so, it's normal for a patient to still be processing and walk out and forget everything you said. And so we need to constantly encourage them to ask questions throughout their treatment. And we're seeing them on a weekly basis. So it's a great opportunity for them to ask questions and keep us posted on how they're feeling and what they're feeling. And I'm really thankful that we do offer those weekly visits, but they can always stop by clinic even on days they're not scheduled to see us.
Great. And how do you balance being honest about a prognosis, right? When you come across somebody who you know doesn't have a good prognosis, while you offer hope or support, like that must be very challenging.
Yeah, it is very challenging, and I wouldn't say I've mastered this perfectly yet. It's definitely part of my training to get more comfortable breaking bad news or discussing, poor prognosis with patients. I am very honest. I don't believe honesty about a poor prognosis means that there is no hope. There are so many ways to find hope, as we were talking about previously.
Mhm.
Despite a poor prognosis, whether that's focusing on comfort, maximizing quality of life, helping them be prepared for what's to come, or discussing what options are available. Um, in the same way, not being honest or holding back from sharing the bad news doesn't always give the patients more hope. I think we empower them by being realistic about what we know and then also optimistic that they could live longer and better lives than what we expect. Like the example you gave
Mhm.
about that patient who's lived many more years than expected. But like I said, this is all much easier said than done. It still
Mhm.
hurts to deliver bad news. I don't think anyone enjoys that. I don't know. Yeah, I don't know that you ever get more necessarily comfortable doing it, but it also depends on the patient. And really getting to know your patient, I think, helps because you can sort of tailor the conversation. It depends on what setting they're in, how much they want to know, how much they can process in one visit versus are you going to, over multiple visits, get to know the patient better and share more as you go and what is their understanding of their diagnosis. The most important thing is that they understand at the end of the conversation their diagnosis, the gravity of the situation and what their options are. And ultimately, once they've been giving all the information, what they decide and what matters to them is what we want to value the most. Um, yeah, I think I find comfort. I know when I started residency and seeing cancer patients almost every day, I um I was very emotional. Like I feel like like the example I gave, I saw my grandmother, I saw my mom, or I would really see people that I loved in these patients. And so I would get really affected when a patient didn't do well or when I saw them suffer. Um, and I think that helped me build connections and build rapport with patients.
Mhm.
But it was hard in the beginning, and over time, I've really found comfort in the fact that we're offering them something, that we have treatment available to help them, even if it's not curative, even if it's not for the outcome that's ultimately desired, that we can help them in some way and support them along the way. I think that I think I do get great joy, and it's really rewarding to do that.
So we're going down into that poor prognosis. Let's talk a little bit about palliative radiation. So often involves very sensitive discussions, right? So how do you approach that conversation about, comfort versus cure? Because sometimes I even get confused at times, sometimes let's talk about brain, like glioblastomas, which we know
Yeah.
really bad prognosis on this brain.
Hmm.
So when you talk about a 40-year-old with a glioblastoma
Hmm.
or a 30-year-old with a glioblastoma, and it's like, the intent. Sometimes I get confused because sometimes I see on you guys treatment like the intent is cure. And I'm like, wait, how is that curing, right? Because it's like, so you can clarify that a little bit. And as well, how do you approach the patient? Does the patient know that this is as bad as sound?
Yeah.
And do you prepare them for like right now you can be okay, but we know that later more likely you won't? Or how do you approach that?
Yeah, again, going back to that initial consultation, that's really the time that you should be telling the patient not just their stage, but their prognosis and how serious is the situation, how quickly do we have to move with treatment if they choose treatment. Um, I always like to ask patients when I'm approaching the conversation of palliative radiation, or usually if we're thinking about palliative treatment, it's because there are no curative options. Otherwise, we would offer both.
Mhm.
Um, and so I like to incorporate in that consult visit to ask the patient what matters to them. And what are their values. And sometimes I'll even ask them what's your source of strength? Who is your support system? And really get to know the patient to understand how they may decide to go about the treatment.
Mhm.
Um, so I try to be honest and straightforward about the fact that, especially if we're offering palliative radiation, palliate means to alleviate. And so the focus or the intent of the treatment is to alleviate symptoms, not to cure the cancer once and for all. So it may mean repeating this several times so they understand that the treatment is prioritizing quality of life and
Mhm.
affirming that this is still a worthy goal if it aligns with what the patient wants. Curative treatment, there are differences between curative and palliative treatment, not just the intent, but curative treatment tends to be more aggressive, higher doses. Um, Most of the time more side effects too. And so palliative treatments tend to be shorter, lower doses, more gentle on the body. And so those are kind of the differences with curative treatment to usually we're treating the one site or the few sites that the patient has of cancer, whereas palliative treatment, many times the cancer has spread beyond what we can just treat with radiation. And so we're just focusing on areas that are causing the patient's symptoms as opposed to trying to control the tumor altogether.
So even in the situation with a glioblastoma that we know is a bad prognosis, and you guys write down like curative treatment, meaning that you're going for high dose because it's localized,
Yes,
and you want to try to just address it as aggressive as you can, but that doesn't mean that you're going to cure them from that glioblastoma, correct?
correct. Yeah,
Okay, that's good.
correct.
No, that's a great clarification.
Yeah.
Because sometimes I feel like I see that and it's like, wait a minute, does the patient knows how bad this is it? And should we start preparing them, right? I usually try to be very tactful and say, right now you may be okay, but I wanted to let you know that if in case in the future you start having difficulties walking, and you and I not be able to walk, and perhaps you may need some assistive device, like walkers and then wheelchair, or perhaps you may need to be taught how to transfer, or even your family, your significant other needs to be trained and transfer. So just make sure that PT is always available for all those
Mhm.
stages. So even if worst case scenario you go downhill, then you have to, as a doctor, to refer you to even home health or anything like that that rehab can really help you with. Uh,
Mhm.
we can just meet you in whatever stage you are. But I try to be very tactful because I don't want to tell them when I see the word like cure, it's like I don't want to tell them this is what you're gonna be
Yeah.
at. Because I
Yeah.
don't know if they're gonna get there, when are they gonna get there, but more
Right.
likely they're gonna get there, right? So
Yes. Yeah. Thank you for clarifying that. Yeah, that's one of those situations where patients typically don't live very long and it's very difficult to cure, but our intent again is for, to give it everything we have in terms of the most aggressive treatment that we have that is safe, and it's mainly for localized disease. So it's not considered a treatment with the intent to just palliate. It's more than that. And so a lot of that is also because we have limited terminology. So we
okay,
call most of our treatments either curative or palliative, but
yeah,
some things
okay,
can be a little bit in that gray area where we don't necessarily expect to cure the patient, but it's not,
okay, got you.
and it's not to just palliate.
Okay, that's very great. I'm so glad we talked about that because we were a little confused at time on that.
Yeah.
Uh, what are some of those misconceptions about palliative radiation that you encounter from patients and families, right? Because sometimes they say, well, this palliative radiation, I don't know if it's going to work because it's going to just make me worse and my quality of life is going to get
Mm,
worse, right? I get
yeah.
a lot of patients that tend to say no to it for that reason. So,
Yeah. Yeah, exactly. I would say that's the most common misconception is that They will relate things that they've heard about radiation in the more curative setting, where the treatments are often longer, higher doses. And so this can lead them to think that they will have to deal with the same difficult side effects. And the reality is that there are side effects anytime we deliver radiation, even with palliative radiation. But again, these treatments are mainly to help the patient feel better and not worse. And so typically they're better tolerated and less aggressive than curative intent treatments. Another misconception may be that the treatment will dissolve their cancer altogether. And so it takes a lot of explaining up front again and throughout the treatment, reminding them that this is palliative. It's not, the intention is not to get rid of their cancer altogether, but is really to focus on their symptoms.
So you want not necessarily, so symptoms mean more pain, right? So most of the time you guys offer palliative radiation when it's more pain control, correct?
Pain control is, yeah, one example of one of a situation where we might offer palliative radiation. It's not always symptoms. Most of the time it is. Sometimes we use palliative radiation to try to minimize the risk of a complication from the cancer progressing.
Okay.
So for example, if the patient has a bone met that's um, in a high risk area somewhere, like the acetabulum, for example, or when they're moving their legs,
Mhm.
it could be easy for them to fracture, something like that. Then we could offer palliative radiation to help control tumor in that area that we're targeting and minimize the risk of them fracturing or having some other complication, skeletal related event. Another example would be using radiation for spinal cord compression. So, trying to prevent it from getting worse and the patient getting paralyzed from the spinal cord compression is using the radiation to target the area where the tumor is compressing the spinal cord or starting to compress the spinal cord, so that we can help reduce the complication. But a lot of times there are symptoms associated with those situations, and so by shrinking tumor in that area, we can alleviate some of the symptoms associated with it.
That's great. And how do you qualify, I'm sorry, how do you define quality of life in the context of your work with cancer patients? How do you use physical therapy to implement that?
Yeah, I love this question. I think this is very patient dependent because everyone has different goals. So for some people, quality of life may mean trying to improve or maintain their function throughout the treatment. Some people might say, I just want to get through this treatment and not have constant pain or deal with the side effects and be able to continue working, or I want to just be able to run with my kids and my grandchildren. And then some people, quality of life is being relieved from the anxiety of
Mhm.
having a cancer diagnosis and wondering if the treatment will work. So I'm thankful that we have resources to help patients in their journeys to improve quality of life. One of those, which I'm a huge advocate for, is physical therapy, and I'm so grateful for the ways that PT helps our patients. Dearly, I'm a huge fan. I'm even a patient of the physical therapist here for injuries and now pregnancy related things. And so I'm a big fan. And I think it's just another tool in the toolbox to help them recover and maintain their function before, during, and after treatment. And I know a lot of patients may be unfamiliar with that when they're coming for treatment. We refer them to physical therapy, but it can help in so many ways, whether that's a breast cancer patient and sending them over to reduce the risk of lymphedema. I know we have a lot of GYN prostate patients that may want pelvic floor therapy, or brain cancer, a brain cancer patient, as you mentioned, working on their balance and function. So there's so many ways PT can help, and oftentimes this is new to them, to the patients. So I really encourage them to implement that early and consistently because it makes a world's difference. And yeah, I always talk so highly about your group, especially because
Yeah.
um, I know y'all are really passionate about taking care of our patients, and you like to get involved as early on as possible during their workup and treatment. And so I highly value that. And I think overall, I think we do a decent job because of our partnership and how close you guys are to us in proximity to you're right next door. So it's easy for the patient go to their PT appointments when they come for treatment and so on.
Yeah, and I appreciate that. And it's something that I love about our program, and really I applaud the trust that actually your mentors put on us a long time ago when they wanted all the patients to be seen by PT, and actually I think that they came up from them, not from us. And when we developed this program and it started to carry on, and it started kind of like when you came as a new resident, we came and did a whole talk to the new residents about like why is PT so important, because sometimes you don't know that, right? You only know a
Yeah.
little bit of what you know on medical school, which is not really that
Hmm.
much because you have to focus so much. So literally, when you come into, you're just learning about radiation oncology. The last thing that you're thinking of is PT, and then when we kind
Hmm.
of come in and explain to you guys all the benefits, it's like, oh my God, that makes so much sense.
Yeah.
And you're right, the whole idea is the early we start, the least, we can mitigate those benefits a lot
Hmm.
more versus just wait until they kind of move or they have more issues with incontinence or they have
Yeah.
pain or lymphedema increase or anything on those lines that, or they will lose so much weight with, head and neck
Yeah.
patients that they're like really become very cachexic and then like where were you all this time, where we could offer so many things to try to keep you going and hopefully divert some of these symptoms that can happen. So we really
Yeah.
appreciate
Absolutely.
that. So um when is so what is the radiation therapy part? And you already kind of mentioned a little bit about prevention, right? It's not just pain, but as well avoid fractures. But what else can radiation do in the context of improved quality of life when
Hmm.
it's not curative?
Yeah, so I mentioned we can reduce complications from cancer progression, like in spinal cord compression, in symptomatic brain metastases is another common referral or consult that we get. We can shrink tumor to minimize related symptoms like pain from bone metastasis, also bleeding from a tumor. Sometimes we will get consulted for, like, for example, a GYN tumor causing bleeding. We can help control the bleeding and help, you know, therefore control discomfort related to these issues. And again, even if we don't prolong life, we can prolong comfort and control the tumor in the area that we're targeting, at least for some time. But those are, I think, some of the most common consults we get, and some of the most common reasons why we would offer palliative radiation. Um, but I'm sure there are more that, that I'm not thinking of right at this
No,
moment.
no, that looks really well. So to wrap up, what advice would you give to the new residents entering oncology, radiation oncology, about communicating with patients?
Yeah, I think it sounds so cliche, but definitely listen to the patient. I know a lot of times we're limited in time. We have lots of patients to see, but um, if you can take the time and ask what matters to them and how they're coping, and I think we often forget to ask these questions either because of our time restrictions or we feel like it's too personal, but I find that most patients like to share and it builds rapport and it helps us understand them better. And I think they appreciate when you care for them as a whole person, including, their mental health, their spiritual health, not just their physical health. So I do feel comfortable going there. I like to go there often with patients.
Mhm.
And I would also encourage any incoming resident to not fear being too empathetic. I know I alluded to that earlier, but I was worried about how I would cope with sad situations. And although there's certainly an element of that in our jobs, like seeing suboptimal results or seeing our patients go through serious hardship or a patient you really connect with passes away. Um, Overall, I found that caring for them emotionally helps make this career more rewarding, and it also drives you to continue learning, researching, improving your practice. Our field is constantly evolving and offering new treatment modalities, and it makes you really want to be a part of that because now you can put a face to the name, and so I think it's inspiring when you connect with patients in that way. And I think overall there are more good days than bad days. We do see a lot of success stories. We see a lot of patients get cured. We have long-term survivorship follow-ups, and so it's not all doom and gloom. There are definitely a lot of really, really great cases and great patient stories that you get to see as well. And so I would just encourage any resident coming in to get excited because it's a great field and yeah, you really feel like you are helping patients day in and day out.
Great. How do you cope with that emotional part? How you take care of yourself?
That's a great question. So I'm pretty much an open book, and I feel like I share my problems with anybody um, who
But
is
that's a
interested
good
in
thing,
listening.
Sometimes
Yeah,
we have to be human. So
yeah,
sometimes you come across, no, we get to, I know you guys don't get to spend a lot of time with the patients, and as we do, so we become, no, we hear a lot of different stories and a lot of different
yeah,
conversations. We have like, 45 minutes to an hour to spend with the patient. So they're come and they're, will tell us or complain or whatever you want to, like how they feel or how they feel like this physician and that physician didn't really pay attention or they really
yeah,
don't care or they just look at the stats and they don't look at them as a patient. They just looking into what the research says and so forth. And then sometimes I tell them the same thing. I'm like, I'm such an open book as well. And sometimes if they cry, cry with them. And it's like, even in the podcast, sometimes some patients like, well, I'm gonna become very tearful. Like, I don't care. We're gonna become tearful together. And that's totally okay. And I'm not gonna edit that. So you'll be who you are. Because all of us go through stuff.
yeah, for
I
sure.
think it's great for you to have that connection with the patient because they get to trust you more, right? So
Yeah,
I think that that
very
works
much
really
so.
well. Yeah, yeah.
Yeah, and adding to my answer to that question, I think talking through it helps me a lot personally. And so I'm grateful that I have a good support system. Like, I, I have my husband, I have family, I have friends. I have my personal faith in God, and so I find a lot of comfort in that. And so I think having people to lean on, and then also having outlets. I really enjoy staying physically active, and you mentioned I enjoy playing tennis, and so sometimes it just helps me after a long day in clinic, maybe a sad day in clinic, to go and hit the
It's
ball
so
as hard as I
helpful.
can and
Yeah, yeah,
get
yeah.
those emotions out. So I think those are some of the ways I cope.
That's
Everybody's
excellent.
different.
Excellent. Well, Erica, that has been so amazing. Really great information. I think our audience is really going to enjoy all your knowledge and great advice. I really appreciate you being part of this show.
Thank you so much, Shirley. It was awesome to join you.
Okay, awesome. So you have a great rest of your day and week.
Thanks, you too.
Okay, bye.
Bye.